As the speakers were talking at dinner last night, dealing with HIV is always a challenge. And you think you have a hold on it, and then there's a curveball, and you have to think your approach all over again. And I think we're really in that right now for our women living with HIV. So I'll start with a case. This is a young lady that came to my office recently. She's 25 years old and, like the girl next door, shocked when she found out that she had HIV. Her HIV is not terribly advanced. Her T count is relatively normal. Her viral load is relatively low. Her HLA test is negative. We can get genotype, sorry, and she was wild type. And she has no comorbidities and no medications. When I raised the question, what are your pregnancy intentions? And she says, never even thought about that. I'm dealing with this right now. So I think when we approach this lady, we're going to choose 2 reverse transcriptase inhibitors, or maybe Pedro will convince you only need 1. And then the question is, which of the third agents are you going to use for this woman based upon a number of factors? And you ask yourself the question, what about women? And is there an optimal therapy for women? And if we look back over the trials, again, most pivotal trials are still in men who have sex with men. And typically, and even today, less than 20% of the trials involve women. Despite the fact that women represent more than half of the epidemic, and I think in Brazil you certainly have more equitability in terms of your gender. So a group of us have been pressuring the companies over the years to do sub-analysis by gender, but even if we do that, the studies are usually not powered to address gender-specific issues. But fortunately, we now have pushed many of the companies to do women-specific studies. So that does allow us to compare drug A to drug B within the women population. But I think if we were to summarize the studies, most of them show that women will do as well virologically as men, but there does tend to be some differences in toxicity. We're not quite sure why and whether that relates to the different body size and mass in a woman, or whether there is different tolerability to different side effects than men. For example, weight gain. Women will not accept weight gain with a drug, and maybe our men will. When we look at the treatment guidelines, and these are many of the leading treatment guidelines now, pretty well everybody is on board that Reltegravir or one integrase inhibitor is really the drug of choice by which we start antiretroviral therapy. And until recently, and I think things are going to change, there's never been any women-specific recommendations. So you should start integrase inhibitors, and clearly from the presentations this morning, that is where Brazil is at. So are integrase inhibitors the right drug for women? Well, there have been a number of trials that have compared integrase inhibitors to, and in all cases it's been atazanavir boosted by ritonavir in women. The WAVE study showed that Stribild, which contains Lvitagovir and cobicistat, was superior in women to atazanavir. Again, not in terms of virologic outcomes, but in terms of tolerability. The OLAY study kept these women switching from one drug to another, but basically showed that both Genvoya and Stribild, again, both which contain Lvitagovir, were superior to atazanavir in women, again, because of tolerability, but also showed some favorable changes when they went to Genvoya in terms of bone mineral density and renal toxicity. And then finally, the AREA study showed that Triumec, which is Dolutegravir with abacavir and 3-TC, again, superior to boosted atazanavir for women. So, easy. Integrase inhibitors should be the right drug for women. And for older women, I agree. This is absolutely the optimal choice of therapy for women starting drugs. As David just led you to understand, there are less issues with drug-drug interactions, and as women age, they're going to be on more other agents to treat comorbidities. There are less metabolic abnormalities with the integrase inhibitors. And as women enter into the menopause and they lose their protective estrogen, this is a time where we're starting to see excess comorbidity in our women aging with HIV. And again, the integrase would be an optimal choice. Furthermore, as you age, we do have a deterioration in renal function. So again, some advantage to using this drug. But what about our younger women? And this is where we have to think about the women's pregnancy choices. And there's usually 2 or 3. 1, I don't want to get pregnant. 2, I'm not sure. Or 3, I do want to get pregnant. And if a woman does not want to get pregnant, then we want to consider an antiretroviral drug that we can use safely with oral contraceptives. And I think, again, as David pointed out, the integrase inhibitors are really the drugs that work best with oral contraceptives without having to adjust the dose. The exception there is if you use Lvitagovir, because the Lvitagovir and cobicistat will increase the progesterone levels of the birth control pill. Now, that doesn't mean it won't work. It just increases the progesterone level, and for many women, that will end up with increased nausea. Boosted atazanavir, which has always been one of the standards for women, can be used with the oral contraceptives, but you have to increase the ethinyl estradiol dose in order for the drug to be effective. If a woman wants to get pregnant, then we obviously need to think about the safety of the drug in pregnancy. And these were the latest guidelines for women living with HIV in terms of what we should recommend during pregnancy. And at that point in time, the third drug was either atazanavir boosted by ritonavir, darunavir boosted by ritonavir, or Reltegravir was the choice, with Lvitagovir serving as the alternative agent to consider. Now remember that these guidelines are often based on expert opinion. They're not often based on a lot of data about the safety of the drug in pregnancy, and we've changed practice. A couple of years ago, our practice was to defer antiretroviral therapy until after first trimester of pregnancy in case there was some potential fetal abnormalities. But now with our change in practice that we treat HIV as soon as it's diagnosed, women now are on antiretroviral therapy often when they become pregnant. So the whole ball game has changed. And so most of the data in the pregnancy registry comes from women who were already pregnant when they started drugs, and there's not as much data as we need in women exposed during first trimester. So what about Reltegravir? And I did have one of my postdoctoral fellows a couple of years ago review the literature on the safety of Reltegravir in pregnancy. We were able to find a total of 278 maternal infant pairs. Now that's pretty low, right? Pretty low in terms of data. 70% of it came from retrospective case reports in series, only a third of it from prospective studies, and only half of it was peer-reviewed. 87% of it from resource-rich settings and may not reflect what's happening in the world. Despite this, the maternal outcomes were really not well reported, and the only consistent finding that we could find in the women was a mild transient elevation in liver transaminases, and whether or not that was related to the drug is really not clear. So what about the babies? And most of the babies were born without any adverse events, and of the ones that were reported, there was nothing consistent to raise any flags. And there were 2 cases of potential transmission. One, however, was probably an in utero transmission before the Reltegravir was administered. And in the second case, there were simply not enough details to know whether or not this was a failure of prevention or whether it was late initiation of drug. So that's not a lot of data at that point. Since that period of time, there has been more information, and perhaps the best source of information comes from the French perinatal cohort. And in France, they have an incredible system, and they really do have access to the results of every pregnancy within the country. So they do have a good denominator. And that's often the problem when we're looking at the safety of drugs, is we often don't know the denominator. So they looked at close to 500 women exposed to Reltegravir between 2008 and 2015. You can see that over time, the number of women who received Reltegravir increased. And their bottom line is that of these women, and this is an important thing when you're reviewing this literature, is that a third of them were exposed in first trimester. Almost more than 2/3 were exposed in second or third trimester, so you're not going to be able to assess fetal abnormalities. But the other important thing is look how many regimens these women were on during their pregnancy. Although half had one regimen, a third had 2 different regimens, and 20% had 3 or more regimens during pregnancy. So if an adverse event happens, which drug was causing the problem, and hence a problem with the literature? What they were able to find in terms of the characteristics of the pregnancy, you can see that there was a small percentage of stillbirths and late miscarriage, and had about a 14% preterm delivery rate, which is very similar to many of the studies that we've seen in HIV-infected women over the years. So in terms of their birth defects, again, noting the potential problems with the data, is that it did not appear to be different in those exposed to Reltegravir in first trimester as opposed to those exposed in later trimesters. And in particular, they were looking at congenital heart disease and didn't note a difference. When you look at the list of birth defects they did describe, I have them on this graph here, they're all over the map. There's nothing consistent. And again, whether or not it's related to the drug is often not clear. For example, congenital CMV. There's no way that that's related to the drug, but it's the way in which we have to report outcomes in studies. Of note, there was no neural tube defect. So this, again, was a comparative study, and oh dear, that's great, it blocked it out. So it was, again, from this French cohort, looking at the different maternal and fetal outcomes, comparing Reltegravir to boosted darunavir and boosted atazanavir. This was presented at CROI, and the bottom line is there was really no difference between the 3 agents in their population. The other place where the integrase inhibitors are being used is clearly in women who present late in pregnancy with the plan of getting the viral load down as quickly as possible to prevent maternal-child transmission. So there was a study that was presented in Brazil, again, a small study that did show that you can get that viral load down very, very quickly, and that 100% of the women were suppressed by 6 weeks. Similarly, a study was done in Thailand in which they were administering the drug with these late presenters, and again, 80% of the population was able to suppress at the time of delivery. So that's a positive thing to do. We hadn't heard anything about Reltegravir PK in pregnancy up until the IAS conference this year, when again the French presented on 43 women who'd been on Reltegravir at conception. They did find that there was a bit of delayed and decreased absorption of Reltegravir in the 3rd trimester of pregnancy, but there was also an increased elimination clearance of about 16% during pregnancy. There were very wide PK levels between the different individuals, and the bottom line for them is that the dose is fine, you don't need to adjust, the PK is fine for the protection of these women, and again, in this small study, they did not show any fetal abnormalities. Lvitagovir is one that we do not use in pregnancy, and that largely came about as a consequence of this PK study in which we found that the cobicistat does not cross the placenta well, and therefore the doses of Lvitagovir in the 3rd trimester of pregnancy are subtherapeutic, and so it is recommended that this not be considered for use for women who are pregnant at the current time until we have more clinical information. Everybody's asking about TAF, and I'm not sure if you have that in Brazil yet, but increasingly in North America, people are using TAF as part of combinations in various situations. This was a PK study that was presented again at the IS meeting, either TAF alone or TAF with cobicistat, and found that the plasma levels were fine during pregnancy. However, I think we need to take caution because we know that TAF levels are lower than tenofovir levels. And so what is important in the prevention of maternal child transmission? Is it the blood level that's important, or is it the fact that you have suppressed viral load? And again, we don't know. So at the moment, it is still recommended that TAF not be used during pregnancy until we can be certain about its safety in the prevention of maternal child transmission. So here was the hiccup. So as the world is getting ready to, or has implemented dolutegravir as the drug of choice, some results from this study were presented at the IS conference in July. So this is a study called TASPAMO, and it was started in August of 2014. And this study was in fact encouraged by the NIH. And the reason for the study is, despite the fact that efavirenz had been the drug of the world, there was still that question as to whether or not efavirenz might cause neural defect. So this study was in fact set up to ask the question, does efavirenz lead to an increased risk of neural tube defects when used in 1st trimester? So that was the hypothesis. And at this time, that was the drug of the world. This study was done in Botswana, and initially a lot of people had concern about the quality of the study, but I'm going to review a few of the factors with you, and I think you'll agree that the study quality was excellent. This was a study that was done in 8 large maternity wards in Botswana, and it represents about half of the pregnancies in that country. They have antenatal records for more than 99% of their women. How they do it. These women pretty well universally deliver in hospital. So there was some concern if a lot of women were delivering at home, maybe we wouldn't have a good understanding of the fetal outcomes, but they all delivered in a healthcare facility, and abortion is extremely rare in this country. It is a country of high HIV prevalence, so almost 25%, and the uptake of antiretroviral drugs during pregnancy is more than 90%, and of which half start before conception. So what they'd done is they trained a bunch of midwives, and when the baby was born, the midwife would examine the baby, and if they thought there was a fetal abnormality, they asked consent from the mom to take a picture. And then all the pictures were sent to a geneticist who, blinded to the mother's HIV status and to their drugs, evaluated the fetal abnormality. So I think those are pretty careful ways of doing the study. So then what happened, here's a natural experiment. In 2016, Botswana switched their first-line antiretroviral drugs from Atripla to tenofovir, FTC, and dolutegravir. So they initially presented an analysis of this TASPAMO study at CROI last year, and at that point in time, they really didn't see any difference between the two drugs. There was no difference in the pregnancy outcomes, there was no difference in adverse events, there was no difference in congenital abnormalities, and I can remember really leaving that CROI conference feeling very confident about using Lvitagovir in pregnancy. But then what happened is they identified 86 neural tube defects in 88,755 births, so again, a really large cohort, leading to an incident rate of 0.1%, or 1 in 100 babies exposed to Lvitagovir in first trimester, 0.1% of pregnancies having this. One issue is that the neural tube runs from your brain down to the bottom of your spinal cord, and the defect can occur at any level of the neural tube. And as you can see, there were problems at every level, which has raised some people to say, well, can we be sure this is a drug if it's happening at different levels of the neural tube? Despite their attempt to have photographs, only half of the babies actually had photographs, the rest were by description only. And a quarter of the neural tube defects were in stillbirths. And of the babies who were born alive, 40% of them died within a month. So this was a very bad outcome for these babies. So this is a graph just showing the point estimate and the confidence intervals for women exposed to different drugs. So the first bar is women exposed to Lvitagovir in first trimester of pregnancy. So you can see that point estimate at 0.94, which in absolute terms was 4 cases out of close to 500 deliveries out of 426. The second bar is women who had started a non-Lvitagovir containing combination at delivery, or were on them at conception. The third bar is those women who were on efavirenz at conception. So I think we can all feel confident that efavirenz does not appear to be leading to neural tube defects, which was the original hypothesis of this study. The next bar was women who started Lvitagovir after the first trimester of pregnancy, so after the neural tube closure, and there were no cases there. And then the last bar is that of HIV negative women, so people in the general population. So the importance of the control group is to make sure there wasn't something going on in the country at that time, a Zika virus or something else, that may have been contributing to this abnormality, but the control group did not seem to show the cases that the Lvitagovir exposed women had. So the problem is, this has been raised. We've been all asked to think about this drug in our women of childbearing potential. Many of the countries are acting on this and suggesting that Lvitagovir should not be used in any woman from 25 to 55, which is a little bit dramatic. And the problem is, how are we going to know? Because the problem is now people are changing behavior, and so the ability for us to truly understand this effect and whether it's real is difficult. And so what's going to go on in Botswana is that they've now expanded their study. They're now going to include the rest of the sites in Botswana. So they will have another 1,200 births that have been exposed to Lvitagovir during first trimester. And then what they've done is this mathematical model and say, well, if we don't find any more, so if this is it, we don't find any more, then the point estimate is no greater than that of the general population, and all of us are going to feel better. If they find 10 more cases, then it's going to be where we're at now, with that prevalence of almost 0.9 or 1 in 100, which is 9-fold that of their general population, and then we're all going to freak out. And then there's that gradient all along the way about how many more we might find. What we don't know, so is it real? Is it truly the drug? We can't be certain. So far, no animal models have shown an impact of Lvitagovir on neural tube development, and the statement is that in any other drug that's caused a neural tube problem, it's always shown up in animal models. So I know that VIV has got a lot of new investigators looking more at animal models to see if there's any signal. The other question is this generalizable? Is this Botswana or is this us too? And is this you too? And the question is, what more will we learn? And I've shown you what more we're going to learn from Botswana, but I think you here in Brazil are so positioned to add to this literature because you've also switched to this drug and you have a large number of women who are having babies and have been exposed to this drug. So I really charge someone in your group to take this on and to try and help us understand whether this is real or not. The question is, what do we do with women and how do we advise them in our clinic? And there's two issues. There's an issue on an individual basis and there's also an issue on a country basis. And when countries are making decisions about antiretroviral drugs for the population, they need to consider the fact that women are getting pregnant half the time the pregnancies are unplanned, and how do you make something safe for everyone? On the other hand, suggesting that no woman between 25 and 55 can have Lvitagovir is not appropriate either. On an individual basis, you can have that conversation with your woman. You can have that conversation as to the risks and benefits and what may happen to her to make that choice. The other thing that we don't know is this a class effect? And that's troubling a lot of us. And given the structural similarity between Lvitagovir and Bictegravir, many people are concerned. And of course, there is absolutely no safety data on Bictegravir in pregnancy. I wouldn't go there. In terms of Reltegravir, so far it looks safe. I know the company is going back and having more look at their databases to see whether or not there's any signal at all. But to this point, we don't know if it's a class effect or not. And if it is, what's the mechanism? Is it dealing with folate metabolism in some way? We just don't know. And so this is a really tough time for all of us to learn how to advise our women properly. And what we're doing in our clinic is that we've identified all women of childbearing potential on Lvitagovir and having an individual conversation with them. So if we can't use integrase inhibitors, where do we go? Do we go back to using protease inhibitors in women? I've already shown you that atazanavir isn't as effective for women, largely because of tolerability issues. We can't go to Lvitagovir because of the pregnancy issues. We can go back to Atripla, but again, we're concerned about the depression associated with that drug, and in particularly in the postpartum period where postpartum depression is fairly common. This was one last slide that was then presented at the conference, now looking at darunavir boosted by cobicistat, which now comes in a single tablet for us. I'm not sure that you have that yet, but they were able to show that the drug levels are fine during pregnancy and postpartum, so this might be an option. So I'm going to close there and say that antiretroviral therapy for women needs to be individualized. And although integrase inhibitors are considered the first-line therapy, you really need to think about the women's pregnancy intentions, the drug interactions with the oral contraceptions, and the potential risks to fetus. Remember that half of pregnancies are unplanned, and the highest risk, if this is real, is during the first trimester before a woman even has any idea that she's pregnant. And so I stress again that pregnancy registries are essential, and I hope you guys can take the lead on helping us get more important information about this problem. I thank you.